Hey you guys, let's go over the anatomy of the stomach. So, the stomach has a role besides storing food, and that is to make chyme. And it controls the rate of delivery of chyme to the small intestines because the food doesn't like just get dumped in. It's actually like slowly like pushed into the duodenum because when you see the duodenum, it's actually pretty small. So food goes in like chunks. So let's go over the topography. It kind of depends because if you do like a nine quadrant analyses, that's really more for like anatomical professors. In the clinical scenarios, we really only use quadrants. So if they ask though, the stomach is going to lie in the epigastric region along with the left hypochondriac, a little bit in the left lumbar, and the umbilical region. And in a clinical scenario, you're just saying it's in the left upper quadrant, and it kind of extends into the right upper quadrant as well. So the entrance of the esophagus to the cardiac orifice of the stomach is about the Z line, which is at T11, and the exit is about L1, which is the pyloric orifice. The esophageal or the cardioesophageal junction is 3 fingers breadth below and like left of the xiphosternal junction. And the pyloric is going to lie on something called the transpyloric plane, and it's only in the abdominal pelvic region and kind of like analyses, but it's in this one, the nine portions, not the quadrants. Lab's triangle is going to be the transpyloric plane at the left margin of the ninth rib, the costal arch, and the liver. So that is where the stomach is in contact with the abdomen wall, and that's important because that's where a G-tube site can be placed. So the stomach will dip in front of the transverse colon when it's full, and if the colon is distended, the stomach will kind of like push upward and enlarge to touch the liver and the diaphragm. That's why like when you eat too much and you haven't completely cleared out your colon, you feel short of breath. So the interior to the stomach is going to be all of this: abdominal wall, left costal margin, diaphragm, left lobe, liver. Above is going to be the diaphragm. Behind is going to be the lesser omental sac, pancreas, the transverse mesocolon, the transverse colon itself, the left kidney, and the adrenal gland, along with the spleen. So the fundus is going to be the topmost part of the stomach, and it is going to be full of gas because gas rises up. Strange. The body itself is going to be from the cardiac orifice to the insula angularis. So insula angularis is like right around here. It just means that it's always going to have that little angle. The pyloric antrum is going to be from the insula annularis to the pylorus itself. And the pylorus is going to be a thick muscular sphincter and like a very narrow canal. The muscular wall will contain longitudinal fibers, circular fibers, and oblique fibers. So this is a pretty strong sphincter. So the muscle of the stomach itself is also 3 layers. There's going to be the circular, the longitudinal, and the oblique. Inside are these folds. They're called the rugae. The angular notch right here. This is the insula angularis. Okay, so at the Z line, the intrathoracic pressure is negative, while the intra-abdominal pressure is positive, and that pressure gradient has to occur in order for the sphincter to work. And the lower esophageal sphincter is going to be reinforced by the right diaphragmatic crus in order to make that high pressure zone right there, in order to, keep the intrathoracic pressure negative. And then the clasp fibers in the stomach will control the tone. The folds of the gastric mucosa, lower esophageal mucosa, the gastric fold, and adipose tissue will make the seal like tighter. And then the pyloric orifice is going to be made out of more like muscular layers with connective tissue septa, and that all like kind of strengthens the sphincter. Unfortunately, it does decrease with age. Like the sphincter tone decreases with age and increases the urge or the risk of getting like GERD and like gastro reflux kind of diseases. Okay, so inside the stomach is very folded, and these kind of work just to compress the stomach when it's empty, and they unfold to expand the stomach when you eat. Inside the gastric canal, also known as the Magenstrasse and the lesser fundus, the rugae, like it's all kind of disorganized at first, and then it becomes more linear and parallel and regular, and like right here, just like, yeah, it's kind of bendy, but still going into like, nice linear routes. Oh, excuse me. And liquids go down this road straight into the duodenum. That's why it's just more efficient for the liquid to just kind of flow down and go. Stomach is an intraperitoneal organ, important to remember, and it has a bunch of ligaments, connects to the liver, and the hepatogastric ligament does form the lesser omentum, and it attaches to the diaphragm and the spleen, and there's going to be a connection to the transverse colon as well, and behind the stomach is going to be the connection to the pancreas by the stomach and the pylorus. So there's the gastropancreatic ligament along with the pyloropancreatic ligament. So the lesser curve of the stomach is supplied by the left gastric and the right gastric arteries. The right will come from the proper hepatic artery, and the left will come straight from the celiac trunk. The greater curve is going to be supplied also by the right and left gastrocephaloploic artery, and the right is going to be a branch of the gastroduodenal artery, and that will also supply the stomach, the duodenum, and the omentum. And the left is going to be a branch of the splenic artery. So the stomach is very well vascularized because there's a lot of anastomosis. The right gastric will anastomose with the left gastric arteries, and that makes an arcade. The right gastroepiploic will anastomose with the left gastroepiploic artery. And then eventually the epiploic and the gastric arteries will unite, and the pyloric artery will pierce the duodenal wall, and that will supply the submucosa, like it will pierce it to supply the inside and the esophageal sphincter, and that will anastomose with the submucosa artery. And the esophageal artery will anastomose with the vessels supplying the fundus. So as you can see here, there's a lot of anastomosis, and they're all very close to the liver. So in hepatic like failure, and there's like portal hypertension, it's going to affect all of these, but mostly like the esophageal artery, because there's going to be like a direct connection to the splenic artery. Okay, so the veins will just drain along the arteries, and they will eventually run along like the curve and then drain into the portal vein. So the varices is during the hepatic hypertension, not the portal hypertension, and it's due to the esophageal veins and the left gastric veins and the abdominal region, so like more up here. In the lower thoracic region, it's going to be more due to the thoracic veins and the azygos and the hemiazygos vein. And too much pressure will cause these to bulge outwards due to the bidirectional flow. And there aren't any valves. So the bidirectional flow is possible, and it usually accommodates the pressure changes. But in the liver disease and the portal vein thrombosis, the anastomosis will dilate. And a neat thing that the body tries to do to compensate for the higher pressure. So the higher pressure is dangerous because these can rupture, and remember all those anastomoses, the person can bleed out very quickly. So in order to kind of like lower the amount of pressure running through the veins, the body will recanalize the old embryonic vessels between the portal and the systemic system. So it's basically like opening up an old sewer system. I mean, it still works, but the valves have become incompetent. So this is not really an effective fix in the long run, because with the usage, it can also create more varices. Okay, so the lymph will follow the vessels toward the celiac and the anterior aortic lymph nodes. The first area like drains up into the right and left gastric vessels to the aortic nodes. Second area kind of drains down outside the stomach, and that will go to the subpyloric lymph nodes, like down here. Third area will go towards like the suprapancreatic and aortic nodes, like up here. Stomach cancer is very concerning because it can spread to any of these lobes and like go nuts. So the stomach is going to be innervated by the splanchnic nerves along with the celiac plexus. It responds to pain, is responsible for constriction and motility. The parasympathetic is going to be the vagus nerve, and that's responsible for relaxation, emptying, and the secretomotor functions. Pain is usually due to stretching or the spasm of smooth muscles, and that refers to like the center of their abdomen, which is the epigastrum. So the stomach is usually, filled with like liquids or soft foods and whatever, and that's why it needs to have contrast, because it's an organ. Usually there's a barium meal that is given, and then a tube can be inserted in down the throat, down the esophagus, into the stomach, and that is going to be the gastroscopy in order to look for the mucosa on stomach cancer. And it's a very uncomfortable procedure. A patient is awake and you have to ask them to swallow in order to get the tube down and to prevent the gagging. So not very fun. So without the contrast, it kind of looks like that. You can't really see too much going on over there. Nasogastric intubation is performed to empty the stomach and to decompress the stomach in intestinal obstruction, or it can also be used to get gastric secretion and feed babies. This is really drastic. We don't really see this unless the patient is elderly and very, very sick, or the neonate is very prematurely born. It's dangerous because you can enter the larynx on accident, nose bleeding due to the dryness or from trauma of insertion, perforation of the esophagus in babies or the stomach because their viscera is not quite strong enough to kind of like handle a lot of bashing. Okay, so ulcers are pretty bad because the majority are usually an H. pylori infection in the lesser curvature at the angularis. That's usually where they occur. Unfortunately, it can like eat through all of the layers of the stomach. So from the mucosa, submucosa, muscle, serosa, and in a chronic case, it can invade into the peritoneum and the neighboring structures. So remember what the stomach is surrounded by. It's surrounded by the pancreas, the liver, the diaphragm, the transverse mesocolon. Like they can go anywhere, and it can perforate the stomach itself, allowing the chyme and the stomach acid to leak into the greater or lesser sac, and then that causes the peritonitis. The most dangerous thing is the erosion of the splenic artery, which lies right behind the stomach. So that is a big old vessel, and the erosion of it is going to be like fatal hemorrhage. You can also cause a very serious bleed from erosion of the left gastric artery. So these ulcers are pretty serious, and you do need to keep them like in mind and perform regular gastroscopy in order to make sure, like, either you've removed it or resected it, or the medication is working and you're treating the pylori infection. Okay, so another complication of the H. pylori infection is that it can lead to gastric cancer because of the constant exposure to the stomach acid. The mucosa is going to be renewed, and first is going to start with the dysplasia, because the body will have to keep on making these new cells like too fast. Like the stomach does, shed its lining pretty often because they are short-lived cells. Like that's fine. But when it's shedding more than usual, there's going to be more immature cells, cells that haven't gone through the right checkpoints. They haven't gone through the amount of screening that other more mature cells have occurred, and it occurs and then it develops into cancer. The metastasis is deadly because remember all of those lymph nodes there, all of the anastomoses. It is pretty bad because it can also invade the nearby structures. So the only cure is really a total gastrectomy. You remove the stomach itself and the first part of the duodenum, along with the esophagus and the spleen and the pancreas and the lymph nodes. That's a lot to be removed. What do you do after all of that? Well, you have to reconnect the poor patient. So it is usually done with a Whipple surgery. Or this reconnection here. It's sometimes you reconnect the esophagus into the small intestine, and sometimes you get is keep the stomach, and then you kind of just reconnect the stomach to the small intestines and the esophagus. So a partial resection is usually for the intractable peptic ulcer. You've tried to treat it, it hasn't worked. We don't want it to kind of go into full-blown cancer, so we just kind of cut that out itself. So usually only the pylorus is removed, but you do have to put them on some kind of anti-acid medication, because there's not going to be any sphincter, and the stomach contents have to be alkalinized in order to go into the duodenum. Okay, so afferent loop syndrome is when the small intestines don't immediately contract, and that is okay because usually it contracts in waves, but the problem is the waves, it takes a little bit of time to contract, and the food can store there and rot, or it can reflux back into the stomach. So look, this is not supposed to be there, and we just treat that by making an anastomosis with the efferent loop. So we just kind of connect it to allow the food just to pass on through, and just kind of ignore the one little area that doesn't immediately contract. Okay, so dumping syndrome is when there is no pylorus to control the chyme, and food from the stomach and the esophagus goes straight into the small intestines. Like I said, without it, without the control, the small intestines aren't ready for the high osmolarity of food, and the liquid will just leave the body using the just because of osmosis. So water from the extracellular fluid will just go right into the lumen, and then that leads to hypotension and tachycardia. You can faint after eating because of the loss of water, and there's going to be diarrhea, loss of water, no absorption of food or water because there's just so much fluid moving in. And there isn't really a cure to this besides management, so you have to drink a ton of water and eat very slow. Okay, so gastric sleeve is one of or gastrectomy are popular procedures here in the West, and it's to treat obesity. Mostly, this could be used to treat stomach cancer, but it's rare. Obesity is far more common, so This is when a gastrectomy, you remove part of the stomach sleeve, you put in like a band in order to prevent so much food from coming in. There's another like version called a Roux-en-Y gastric bypass, and all of this basically controls how much food can come in and to feel full faster and longer. Vagotomy is going to be like cutting the vagus nerves, the innervation. There's a couple different ones. The truncal is going to be like everything's going to be gone, right? Selective is going to be cutting the vagus nerve innervation to the stomach, not just like, you know, all the surrounding structures. Proximal is going to be very, very selective. And they're done when you can't treat the gastric ulcer and you really don't want to like resect the trunks. Like, this is not what you do, because the trunks will they will innervate the other surrounding structures. Remember, like, the vagus nerve surrounds supplies a lot of the intestines. So a truncal vagotomy is going to stop the solid emptyings and the secretion of acids and increase really the emptying of liquids. As the selective is going to suppress the acid secretion, and the highly selective vagotomy is going to stop the nerve stimulation to the stomach, but it still allows the peristalsis. So that's it for now. Thank you for your attention and good luck studying.